Hello, I am Dr. Everton Prospere. I'm a medical attending in the Department of Medicine at SUNY Downstate Health Sciences University. I'm also the director of the Geriatric Medicine Fellowship, and I'm a co-director of the Brooklyn Initiative to develop geriatric education. Today's session, which is a self-learning module or SLM, is on geriatric syndrome, and this is the first of 3 sessions on geriatric syndrome. So today's session is actually geriatric syndrome 1. I have no significant conflicts of interest or financial disclosures. However, this presentation is supported by a grant from the Health Resources and Services Administration of the United States Department of Health and Human Services. This is a list of some of the commonly used acronyms or abbreviations that is going to be used in this presentation and some of the subsequent self-learning modules. HRSA, GWEP, Bridge, SIAD, 4Ms, Bridget, ADRD, Bridge Gap, ECHO, and SLM. This is a list of the curriculum. This self-learning module is part of a broader curriculum or Bridge self-learning module. The components of that curriculum is the comprehensive geriatric assessment, 2, the wellness and functional ability, 3, interprofessional teams and interprofessional care of older adult, 4, age-friendly healthcare systems, 5, dementia-friendly communities, 6, geriatric syndromes, 1, geriatric syndromes 2, there's also going to be geriatric syndromes 3, 8, culturally and linguistically competent healthcare of older adults, and 9, ageism. This slide represents a snapshot of all the various locations or environments where we can actually find older adults. And it ranges from, critical care setting in a hospital to the patient's residence or even outdoors. This slide summarizes the 4Ms framework or the 4Ms age-friendly healthcare model. The age-friendly healthcare model is an initiative by the John A. Hartford Foundation and the Institute of Healthcare Improvement in partnership with the American Hospital Association and the Catholic Health Association of the United States. The 4Ms framework takes into account what matters to the patient. It also takes into account medications and polypharmacies and potential for adverse outcomes and drug-drug interactions. It takes into account mentation, including depression, dementia, delirium. It also takes into account the patient's mobility and functional status. In the 4Ms framework, the intent is to emphasize that every older adult is entitled to comprehensive geriatric care, and the 4Ms model is one of the best framework under which to ensure that every older adult gets comprehensive, age-friendly care. So the objectives for this session, Geriatric Syndromes 1, is by the end of this presentation, the attendee or the learner should be able to define a geriatric syndrome. The learner should also be able to describe the specific geriatric syndrome of frailty, undernutrition, and obesity. And the learner should also be able to identify the diagnostic and therapeutic approaches to the management of frailty, the management of undernutrition, and the management of obesity. So let's brainstorm for a minute. What is geriatric syndrome, or what is a geriatric syndrome? What's the definition of a geriatric syndrome? So a geriatric syndrome is a group of signs and or symptoms that tends to occur in an older adult at a rate that is more frequent than it occurs in a younger adult. And those signs and or symptoms, they tend to characterize a particular abnormality or a particular condition, such that those signs or symptoms include emotions and or actions that usually form an identifiable pattern. And those abnormalities or those conditions tend to occur more frequently than is likely due to chance alone. So why is this relevant? This is relevant because we practice evidence-based medicine. We practice an evidence-based standard of care. What's the strength of the evidence supporting or guiding our decision-making process? Is the evidence, is the data consistent? Is it patient-centered? Is it reliable? Has it been validated? This is relevant because whatever we do in medicine, our assessments and our intervention should translate into an improvement in quality of life and or life expectancy. Another way of saying that is that our assessments and our interventions, whatever we do, should result in a decrease in morbidity and mortality. And that should be guided by the 4M's framework model. What matters to the patient, aligning our goals and care in accordance with the patient's will and the patient's wishes. It should be aligned with the patient's, taking into consideration the patient's mentation, the patient's mobility, the patient's medications. So whatever we do should impact quality of life and life expectancy. And there's evidence to show also that our intervention will impact the patient's ability to perform activities of daily living, instrumental activities of daily living. And the overarching goal is to promote independent functioning by limiting disabilities and limiting dependency.